Almost any cardiac intervention will perhaps lead to some myocardial injury. But with TAVR, as Kim Eagle, who's the editor of ACC.org, said recently, you look at a patient afterwards and it's a little alarming. So you do wonder sometimes. Therefore, predictors and clinical impact of myocardial injury following TAVR is the insight from a large multi-center registry, and it is coming up in the November 10th issue of the JACC. So for today, I'm with the first author, who is Dr. Josep Rode, s-Cabau, who is an MD at the Quebec Heart Lung Institute and the Laval University. Let's start off. Why did you do this study? Have you seen some of those patients after TAVR and go, good heavens?
In fact, we had evidence that the incidence of myocardial injury, sometimes small, sometimes more important, was very frequent after TAVR. And the idea here was, in a relatively large cohort of patients, to determine the predictors, but also the impact on clinical outcomes of this complication.
So tell us about this, because this is actually a real-world study, correct?
Mm-hmm. Yeah, that's exact.
So it's coming up in JACC. What did you find?
We found that we used, I would say, for the first time, only CK-MB values for determining myocardial injury. And we found that about 2/3 of the patients had some degree of myocardial injury as determined by an increase in CK-MB. When you look at the patients who had the procedure through transepical approach, and this is well known, all of them, or nearly all of them, had some increase in CK-MB values, and about half of the patients who had the procedure through transfemoral approach. And what we found is, for sure, transepical approach was the most important predictor of myocardial injury. But then we found that significant complications like major bleeding, like valve embolization, need for a second valve, and even the learning curve were also associated with a higher degree of myocardial injury.
So what do you take away from this in terms of, do you think it's now possible to recognize after TAVR a higher risk patient that might need closer follow-up?
This is the idea that we pointed out during the discussion in the paper. In fact, a higher increase in a higher degree of myocardial injury was associated with poorer outcomes, meaning increased mortality overall and cardiac, and it had also an impact on left ventricular ejection fraction. I think that probably not all these patients, very mild increases in CK-MB values doesn't mean much, even if you increase a bit the risk. But when you have a significant increase, I think that sometimes we do with PCI patients, you have to consider that these patients need probably a closer follow-up in order to see the changes in left ventricular ejection fraction, in order to see whether other complications may appear, like heart failure, etc.
Would you change or emphasize more what they're on, like an ACE inhibitor or beta blocker? Would you change that at all in terms of patients that you think might be at higher risk?
In real world, I don't think so. I don't think either that we have any data that supports this, but at least to our knowledge that this might be a problem, and that is not extremely infrequent, I would say, is quite frequent. I think that it was important in a large cohort of patients.
Right. So what's the bottom line message? What's the take home you want someone to take away from this paper in JACC?
I think that the take home message is that myocardial injury is a very frequent complication of these procedures, through different probably mechanisms that can be improved. The rate of myocardial injury can decrease with increased experience, with less problems in terms of valve manipulation, embolization, need for second valve, etc. Probably the idea would be also in patients, especially with low ejection fractions, maybe to avoid the approach that is associated with a higher degree of myocardial injury. That means the transepical approach, use alternative approaches. And then that it's probably worthy to measure these biomarkers after TAVR in order to better stratify the patients before hospital discharge.
Well, the paper is in the November 10th issue of JACC, so please take a look at that and the accompanying editorial comment. For Cardiol Source World News, I'm Executive Editor Rick McGuire.